Okay, so suture comes in a pack, and to remove the suture from the pack, we generally use our needle holder. I'm holding the needle holder in a tripod grasp at the moment with fingers, my thumb and my fourth finger in the rings, and then my middle fingers are acting as a tripod just for stability on this needle holder. With the needle holder, we can pick up the needle out of the pack and then pull the suture out of the pack. It's important never to pull away as far as you can go, because you don't know if you'll touch a lamp or if you'll touch an assistant or someone who's not sterile. So you really always want to keep your instruments in your field where you can see and you know it's sterile. And now this can be discarded in our bowl. The way we hold the needle in a needle holder is such that we want to hold it at approximately 2/3 or 1/3 and 2/3 of the curve of the needle. So we can see this here. And so not in the middle of the needle, because then we don't have a very long working length. So at about 1/3. And then we want to hold it at the tip of the needle holder as opposed to the middle or the bottom of the needle holder, because that again really reduces our range of motion. So right at the tip and at about 1/3 of the needle. And that allows you, by rotating your wrist, to actually get quite a range of motion with that needle. The surgeon can either hold the needle or can actually clamp the needle holder onto the needle. It's very much a preference or surgeon choice. And whether you clamp it once, 2, or 3, generally people just clamp it once onto the needle if they are to clamp it. Now, suture, when it comes out of the pack, has a bit of memory. So this is PDS. It doesn't have too much memory compared to some sutures, but it still has a little bit of memory. The way to remove the memory is to stretch the suture material slightly. Now, there are a few important things to remember. We don't want to hold the needle and stretch the suture off the needle, because the swage will loosen and we may lose our pack of suture and have to use a new pack, which is a waste. So you really want to hold the suture and hold the suture at the other end. Then you want to stretch it slightly, just enough to remove that memory, but without actually stretching the suture into the plastic deformation phase of the suture. So if we stretch it gently, we remove that memory, we're still in the elastic deformation phase, where the strength or the strength of this material has not changed, and we still have a material that's nice and strong to hold the tissues. The other thing is we never want to handle suture with our needle holder, or with our thumb forceps for that matter. Any handling with an instrument happens either on the needle part or as we suture on the tip that's actually going to be cut, but never along the strand of the suture, because that's very damaging to the suture. Now, while handling the suture, it's a long strand, we want to be sure it doesn't fall off our field. So we can sort of bunch it up on our field and keep it loose, or we can hold on to it loosely in our fingers. Some people like to wrap it around their fingers. I find that a little bit difficult. It gets all raveled and sort of knotted. So personally, I just hang on to the strand of suture to make sure it stays in my sterile field. Now, the handling of the thumb forceps is very important. We want to handle these thumb forceps in a thumb grip or pencil grip. So between the thumb and the index finger, and the forceps resting on your index or in the groove between your index and thumb. And now for people with very large hands, this may have a tendency to fall in the groove of your thumb, but you still need to hold your thumb forceps like a pencil. I want to see nobody holding their thumb forceps like a barbecue tong or a tweezer. You really don't have very good mobility or very good dexterity when you hold a thumb forceps this way. So truly between your thumb and index finger. Generally what we do is we hold our needle holder or our scissor in our dominant hand, in this case my right hand, and our thumb forceps in our non-dominant hand, in this case my left hand. As a right-handed surgeon, I will do surgery from right to left, because then my instruments never cross. If I were to do surgery from left to right, I would have to cross my hands to pick up my tissue, which would be awkward. As a right-handed surgeon, I will also tend to have my instrument table to the right, towards the right hand, so it's easily accessible and I don't have to cross over my field to pick up my instruments. And I will have the anesthetist and the anesthetic machine to the left of my surgical field. So in a patient, we would likely have a gauze ready as we cut so that we could dab any blood after cutting. Obviously, Daisy is not likely to bleed much, so we won't have a gauze here. The other thing is that the gauze can be used to cover or to protect your gloves from contact with the skin as you stabilize the skin when you cut. So simply cutting sometimes works, but in patients that have loose skin, you need to stabilize the tissues as you make your cut. The way to hold your scalpel handle is either as a finger grip, as I have here, so between your thumb and then your index and middle finger, or you can hold it as a pencil grip as well. The pencil grip gives you a bit of a tendency to cut with the tip of the blade more so than the body of the blade. If you look at the blade, really, you get a much better cutting area if your blade is flat on the tissues, and you're less likely to have to make multiple cuts into your tissues. So we'll use the finger grip here and the flat surface of our blade, and we will just make a cut in our patient. So cutting, you want to be sure to cut mostly the skin. You'll always get a little bit of subcutaneous tissues as well. You may need to go back and just make that cut a little bit deeper. Daisy, of course, is a little harder to cut into than a regular patient. And we can see here in Daisy that we have skin. It just demonstrates skin here at the edge, and then we have the dermal tissue, which is the white layer. We have a few little vessels here, and then some subcutaneous tissue. We have not reached our linea alba yet. Those small subcutaneous vessels could be ligated, so we could use a curved hemostat. We could clamp just with the tip of the hemostat the vessel itself, and then apply a ligature to this vessel for hemostasis. So we can ligate this little vessel with a small diameter suture. This is a 4-0 biosin. Here we can see a little bit more memory in this material. We can stretch to remove the memory, again holding the suture, not the needle. And we remove the memory such that it helps us suture. It doesn't want to keep moving along the shapes of the suture. So we now wrap the suture around the forceps, and we want to expose the tip of the forceps. We can do an instrument or a hand tie here. We'll do an instrument tie for demonstration. We want to bring a short end of the suture, and we will start between the short and the long strand, wrap around once. We don't need a surgeon's throw. This is a small vessel. Cross our hands and tighten. And then we can do this 3 times. 3 throws for these vessels is usually sufficient. And then we can cut the ends of the suture very short and release our hemostat. And now we have hemostasis on this vessel. So the tips for suturing. Again, we hold our needle holder in our dominant hand with our instrument being held through the rings by our thumb and our 4th finger. We hold our thumb forceps in the left hand in a pencil grip. We want to try and prevent handling the tissues as much as possible, because any handling of the tissues with the thumb forceps is traumatic to the tissues. When we suture, we generally suture from the other side of the table towards ourselves. So the needle always comes through the tissues and towards ourselves rather than away. So this would be awkward if you go away from yourself towards the opposite side of the table. It's much harder on your wrist. So always suture towards you. So we have the needle coming away from ourselves towards ourselves, and we can either go across both sides of the tissue at once, and I'll demonstrate this now and then show you the different option after. You can notice here we're going to stabilize the needle with the thumb forceps, and if we can see this, I'm not picking the needle up with the tip of this forceps. I'm actually picking it up behind the tip of the forceps, compressing enough that my needle is stable, and then I can either pull on it a little bit and then come and re-grasp with my needle holder to finish the pass of that needle through. The other thing you want to do is follow the curve of this needle. So if you see it's a curved needle, you have to rotate your wrist in order to pass that needle in a curved fashion. If you don't, what happens is that you will hear that the tissues are being damaged. So if I try to pull this straight here, you probably can hear the damage to the tissues. It's much harder to pull this through the tissues. The alternative is to go through one side of the tissues, stabilize the needle, pick it up with your needle holder, and come around again and do the second side of your tissues here. And this is helpful when there is a wide bite of tissue to be taken. Now, I don't know if you notice what I've done here, but as you pass your needle through your tissues, you then need to pull your suture through. This is a long strand of suture. It's a new pack of suture. And what I do is I pull the suture out bit by bit. And you want to do this rather than pull the suture out all the way away from yourself, because then who knows what you might touch, a light or an assistant, and you may contaminate your suture or your instruments. So now we're ready to tie a suture here. The technique for tying a suture is to always have a short end of your suture and the long end, which is the needle end of your suture, in your left hand. You can see I'm handling my suture with my fingers. My thumb forceps are not palmed. If you're not comfortable palming your forceps, you can move the forceps aside while you suture, but there's no need to do that. You can palm them. So you want to identify your long end and your short end of the suture, about an inch or so of suture. You place your needle holder between the two sutures, and that's very, very important. And then you will wrap your long end of suture around the needle holder once. Pick up the tip of the suture with your needle holder and then cross your hands. So if the small end of the suture is opposite to you and the long end is towards you, you will move your hands such that the long end ends up on the other side of the table and the short end is towards yourself. Now, this daisy has a little bit of tension, so we can see my suture doesn't hold. We have a few options here, one of which is to let go of our throw and to actually place a surgeon's throw, which should help us with tension. So the surgeon's throw is placed on the first wrap of suture, so the first throw. We start again the same way with our needle holder between the long end and the short end of the suture. We wrap around our needle holder, but this time we wrap around twice. And then we pick up our suture end and we again cross. So the long end goes opposite and the short end comes towards me. And now you can see that extra throw allows us to keep our tension on the suture, and it allows us to tie our second throw without loosening. The one thing that tends to happen is that if you pull on this long end of suture, the suture can sometimes loosen as well. So instead of pulling up, you really want to keep this end of suture nice and loose throughout your suturing process. So now that we've done one throw, we now need to place 2 or 3 or 4 more throws depending on the suture material we use. So we now start again between the long end of the suture and the short end of the suture. We don't start outside of our suture strands. So between the long and short, the short is on my side, so it will ultimately end on the opposite side by the time this throw is over. So start between, we wrap around only once at this point. We pick up the tip of our suture and we cross. And as I cross my suture, you can see this forms a beautiful circle. That is a square throw. If I were to hold up on the short end of the suture, you can see how a slip knot tends to form very, very easily, and this is not a square knot. So what you want is to leave your hands nice and loose and to pull parallel or straight across, horizontal towards your patient, such that your knot falls as a square knot. And I'll demonstrate this again. So now we still have a long end and a short end. We start in the middle, wrap around once, pick up the tip of the suture. Don't hold it up, because if you hold it up, you will have a tendency to form. You can see here a half hitch. You want to keep your hands nice and loose and pull flat onto your patient so it forms that circle and a square knot. And you want this to be relatively tight. Your knots need to bind to themselves. The throws need to bind to themselves. So if you see looseness in between your throws, it's not tight enough. We'll apply a fourth throw, again starting in the middle between our short and long end, wrap around once, pick up the tip, and I'll just demonstrate here. If you were to pick up your suture midway through the suture rather than at the tip, what happens is that that long strand of suture prevents you from actually passing that suture over. You have to tug in this instance to do it, and that often ends up creating a half hitch there. So you really want to start in the middle, wrap around, and pick up the tip of the suture as much as possible, and then keep your hands loose, forming this circle, a flat or a square knot, and bind it to the previous throws. We have 4 throws now. We can cut the suture. We have the short end, which is being held by our needle holder. We leave the needle holder on here, and with my hand I pull the long end tight, and that allows you now to cut the suture ends. If this were skin sutures, we would have placed these much looser, so we'll pretend this is as tight as a linea alba closure would be. And on a linea alba, or abdominal closure, we would leave these sutures relatively short. So 3-4 millimeters at the most. We could even go a little bit shorter than this. If I was to demonstrate a skin suture, the skin sutures, again, we tend not to handle the edges of the skin when we do them. And we'll demonstrate here cruciate for the skin. We want skin sutures to be nice and loose. So we would apply these with much less tension on the suture as we tie it. So we no longer need that surgeon's throw because the suture is going to stay loose anyway. We apply a first, so again, I just made a cross equidistant square. We start in the middle between the long strand of suture, wrap around, pick up the short end of suture, and cross. Then we do the same. In between the long end and the short end, again, I'm not pulling up on my suture, because if I pull up, you can see how this actually unravels my suture. So you want to leave your hands nice and loose at all times. Start in the middle, wrap around, pick up the tip of the suture, and see how loose this has become. We can actually tighten this down to the desired looseness, and that's about as loose as we want a skin suture. Now my first and my second throw haven't bound together yet. I wait till the third throw to actually tighten it tightly, or else it will tighten all the way down. So start in the middle, wrap around, pick up the tip of the suture, cross my hands over, have a square knot, and now I can tighten this down all the way at my third throw. And we'll just add 2 throws to finalize this. So wrap around from the middle, pick up the short end, and cross. And as the end becomes smaller, it becomes harder and harder to create that square knot. And again, keeping everything loose, forming that square knot. Now this is an absorbable suture material. To do sutures on the skin, we would use a non-absorbable suture material on a cutting needle rather than a blunt needle. The skin sutures we cut with longer tags. We have to remove these in 10 to 14 days. So we usually leave tags that are slightly longer than we do for other sutures. Some people try to leave the tag off to the side of the incision. Honestly, they tend to roll back in, and it's not a big issue. It does not impede or impair healing.